Okay guys, so today we'll be talking about how do you approach a case of mass per abdomen, and here I have taken a sample as a case of right iliac fossa mass. So what happens? Suppose a patient present to you with chief complaints of mass per abdomen, and maybe he may present with other complaints of nausea, vomiting, pain or some other thing. So when you start examining the patient, so how do you differentiate whether the mass arises is parietal or is intra-abdominal? So first, in order to differentiate between parietal and intra-abdominal mass, you do a leg raising test of Carnet, which is also known as test of Carnet. And so you differentiate between parietal and intra-abdominal. So how does parietal mass? It will become more prominent parietal mass on raising the leg. And how will intra-abdominal mass behave? It will become less prominent. So now this is the way you can differentiate between parietal and intra-abdominal mass. So now in intra-abdominal, so when it lies in the abdomen, what are the two possibilities? It is within the peritoneum and it is beneath the peritoneum, that is extraperitoneal or retroperitoneal. So how do you differentiate between retroperitoneal? So what do we ask? So we see, does the mass falls forward or not? So this is the typical finding. We see the mass falls forward. So if it falls forward, then it is a intraperitoneal. If it does not fall forward, it is a retroperitoneal. So what books typically describe is the knee elbow position, but practically it's not possible. So instead of knee elbow position, practically what do? We check it in a lateral position. We do it in a lateral position and we differentiate whether it is a retroperitoneal mass or it is a intraperitoneal mass. So like sample example, what we say, if we talk about the right iliac fossa mass, so what are the parietal? So anything that arises from the fat, like lipoma. If it arises from the muscle, desmoid tumor. If it is a iliac abscess which goes in the abdominal wall, or if there is a appendicular abscess. So these are example of parietal mass. So coming on now to the intraperitoneal, that lies within the peritoneum. So what is this? So it can be either appendicular mass, most common location, ileocecal TB. So why ileocecal TB? Ileocecal region is the most common because there is stasis plus lot of Pierce patches. So as a result, you can get ileum and cecum to involve. There can be mesenteric lymph node. CA cecum is one of the most common cause. Typhoid ulcers can happen if it is distended gallbladder. So which law does it fit? It fits into the Courvoisier's law. There may be other gynec pathology that may cause it. Now coming on to the retroperitoneal mass. So what are the structures in the retroperitoneum? You have muscles like psoas muscle. So psoas abscess. You have arteries, aorta and other arteries beneath it. So aneurysm may happen. And this is the one of the most famous DD. Like when you are examining the patient, like if suppose there is a 10 or 12-year-old child, and if you see there is only one testis and the other scrotum is empty, and so it may be case of undescended testis or kidney. So this basically sums up how do you approach a case of mass, and more specifically right iliac fossa mass.